So first of all, let me say welcome to everybody in the room. Thank you so much for joining us today for this patient experience conversation. My name is Gail Dobell, and I am one of two directors in the Health System Performance Branch at Health Quality Ontario. Before I introduce the panel that we have before us and go through the agenda for today's session, I'm going to just take a few minutes to do some housekeeping rules. And I'm sure you've seen this from other presentations you've already attended today. None of the panel nor this session in particular received any commercial support for doing this, so I've done my job and gotten through those slides. The next one is, and I know there's been a lot of activity around the tweeting, so tweet away quite happily, and that is the hashtag for today. In terms of other housekeeping details, the slides that we'll be talking about today and the contact names and the references for today's presentation will all be available on the Health Quality Ontario website within the next few days following the conference, so please, no need to take notes if you don't want to. I also wanted to let you know that we've reserved some time at the end of today's session for some Q&A, so we're going to actually hold questions until the end of the session, if that works for everybody. So in terms of learning objectives, my hope is for today's session is to take us on a little bit of a journey that will help to illustrate how far patient experience measurement has come, where we still need to go, and why it's really important that we get there. I'm going to start off by doing just a little bit of a content overview on patient experience, and I'll reiterate that this is an overview that I'll be doing. Excitingly, there are whole conferences now dedicated to patient experience measurement, and we've got 75 minutes. But what I hope we can do in this next little while is to present some unique perspectives of activities that are happening in the province, and that will make this 75 minutes somewhat unique and not try to cram 2 days worth of a conference into this short period of time. What we're going to be doing today is hearing from 4 different perspectives. We're going to start off with the cornerstone of patient experience measurement and the perspective of the patient. And to start us off to do that, we have with us Elise Maybe. Elise has had several encounters with the healthcare system personally, which have contributed to her very strong belief that patients need to help drive the changes in healthcare system. As a part of her dedication to bringing the patient voice to healthcare, Elise has been a hospital patient and family doctor advisor and has been a patient representative for Patients Canada, working on their measurement committee as well as the research management committee for the technology network. After Elise has given that patient perspective, we're going to hand the podium over to Jennifer Hartwick. Jennifer is going to be speaking to us from the provider perspective. Jennifer has had several positions with Schlegel Villages of long-term care homes. They operate 5 continuum of care communities and 7 long-term care homes in Ontario. Jennifer's role as Director of Business Processes and Development supports design, implementation, and early monitoring of new projects, such as quality of life satisfaction survey, as well as quality improvement protocols and tracking processes across the organization. Georgina Veldholst is also with us today at the podium, and Georgina will be speaking from the LHIN perspective. Georgina joined the LHIN in June of this current year and is the Director of Planning, Integration, and Community Engagement, and she brings with her her experience in organizational transformation, stakeholder engagement, issues management, and this is from her time with the LHIN, as well as North York General Hospital, West Park Healthcare, and the Centre for Addiction and Mental Health. Our last speaker on the panel is Kira Lieb. Kira is joining us from the Canadian Institute for Healthcare Information, where she is also a director in health system performance management and works on a number of projects. Quite specifically, and closely related to this, is Kai Hai's Your Healthcare System websites. We'll finish off the question, as I said, or excuse me, the session with some summary and a bit of some themes, and then we'll move into the quality improvement question and answer section. It's all about quality improvement. So in terms of me, and starting off with that little bit of the overview of patient experience measurement, this particular slide signals the phenomenal and growing interest in patient experience measurement, and whether it's for the purposes of quality improvement, accreditation, accountability, public reporting, or other. what was once this huge scatter plot of activities with very few correlations, we now can show a scatter plot that has a really nice trend line of activities taking place in this particular construct. We have come to realize how measurement in this particular area can drive quality improvement, and not only is it the right thing to do, but plays a huge role in changing patient and provider behaviors, processes, and outcomes of care. Joshua Tepper, when speaking with me about this, talked about an epiphany that the system has had, where we've moved from an evolution of a system where it was sort of, I will say, benevolent paternalism to a system that is very much patient-driven. Another way of describing it is this healthcare system that was designed to care for patients to a system that provides care with patients. I'd like to think that patient experience measurement is a cornerstone of that transformation that we have had, that evolution that's taking place. While we've had a lot of consensus in terms of the direction patient experience measurement is going, where we haven't got as much consensus is the definition of patient experience. So patient experience is very often used interchangeably with patient engagement and patient satisfaction. These terms actually mean different things, but the important thing is that there are a number of different definitions that are out there, and individuals and organizations are using, for the most part, ones that meet the needs for their reporting, or meet their reporting needs. These blue words that I'm putting up, while these definitions are different, start to signal that there is some overlapping and aligning language that we're starting to see. Things like interactions, perceptions, expectations, subjective and objective. These are all key words that are coming up. An interesting study was done by the Dobell Institute in the United States that identified that the importance, whatever definition you use, the importance of having a clear definition to guide your patient experience measurement work was critical, and that organizations that chose or created a patient experience measurement definition to guide their work were the ones that actually ended up being most able to drive improvement in patient experience measurement. So using a formal definition helps us to support the work and achieve results. These next few slides talk a little bit about the question why. And I think we probably all have something in our minds, but there's different perspectives as to why measuring patient experience is important. Just to set the framework for each of our panelists that will be speaking about it from their own perspective, what I'm going to do is just sort of highlight some of the key pieces for each. So from a patient perspective, we all know that the patient themselves is the best source of information about the patient experience itself, goes without saying. But beyond that, what we do know, and I think Elise will expand on this, is that measuring patient experience really captures the individuality of the person being spoken to, but also gives us an opportunity to roll that up so that we can report it more broadly than the individual level. The patient also, patient experience measurement also provides the patient with a structured mechanism to provide feedback. We know patients want to be listened to. This is the opportunity for us to make sure that we're collecting that information in a systematic way. We also know that the patient experience measurement is important to providers. So it contributes, obviously, to quality-centered, patient-driven culture, but it also has a great deal of increasing literature coming out now that shows the relationship between improved outcomes and to improved processes, efficiency, and patient safety. And if that wasn't enough, it also has the opportunity to help us meet some legislative requirements. From a systems level perspective, patient experience measurement informs policy development, transparency, and accountability, and provides an opportunity for us to push improvements, best practices farther, faster. I'm going to go a little bit quicker now because I see my time is running out, but I just also wanted to mention that there are a number of different approaches to patient experience measurement. We all know about patient surveys, and there's the traditional ones, but there's also some new and emerging ones like experience-based design, We also have focus groups, one-on-one interviews, observational studies, and qualitative analysis of patient stories. They're all different approaches used to collecting patient experience information. I've made a note on this particular slide. There is a difference, though, between this and some of those reported RateMDs, Angie's List, and Yelp, and some of those other methodologies that may not capture as diverse a range of the population of patients. So we need to just keep these things in mind. Finally, before I turn the podium over to the panelists, I just wanted to sort of play around a little bit with some visuals that we've been working with. So there's an awful lot of activity that's happening in the province around patient experience measurement. And this visual, the first of a series, is to start to get toward what that means. And what we just wanted to identify was locating the patient at the center. There's patient experience measurement that's happening at the facility level, and then at the network level, the regional level, the national level, and the international level. But in addition to that, there's activities happening for quality improvement purposes, for accreditation, accountability, and ultimately public reporting. But there's also activities happening at the cross-sector level as well as at the individual sector level. So this starts to frame a little bit of the complexities that we're working with in terms of measuring patient experience and reporting patient experience. One of the key things that we know about is that there are many, many, many tools that are out there that are being used at some point on this airplane engine visual. And it's hugely important for us to be able to understand what the activities are to make sure that they are aligned and coordinated. So that's enough of an overview from me. I'm now going to pass it over to Elise, who's going to talk about that patient perspective.
Okay, good afternoon. So my name is Elise Maybe. I'm with Patients Canada. Whoops, I want to go back. And I've been with Patients Canada for about 3 years as a volunteer. The primary work that we do is to take patient stories and patient experiences and look at them, examine them, and see what learnings we can get from them, and from those learnings develop what we call key performance targets, or KPTs. So those are targets that would identify actions for change in policy, processes, and in training. So that's, if you will, my background. The thing that going through all of these different stories from other people has done for me is it's given me a broader appreciation beyond my own experience, which I will dive into in a moment, of what the issues are for patients as we journey across the system. So now I'll go and tell you a little bit about my story. We've heard some amazing patient stories. I'm afraid mine is rather mundane. So about 2 years ago at Thanksgiving, we'd had a wonderful family meal. Everybody had gone home. I collapsed on the sofa to relax, and I thought, oh, not feeling too well. Maybe I had too much turkey. And then the pain got worse, and it got worse to the point where I was gasping for air. Because it was Thanksgiving, there was no point in calling my family physician. Anytime I called them after hours, I got the, please call the emergency department. And so that was going to be useless. So I called Telehealth Ontario, and I've had some experiences with them, and they've all been positive. And I thought, well, maybe she'll tell me it's just indigestion. But after a back and forth with Telehealth, she said, well, there is a possibility you're having a cardiac event, which pretty much gave me a cardiac event. And so she said, I'm going to call the ambulance because, and I said, oh no, my husband can, no, I'm calling the ambulance. So I had the embarrassing experience of being toted out by the ambulance. The EMS guys were terrific. They were calm, they were professional. I thought, oh well, if I am having a cardiac event, at least I have people around me who know what they're doing. They took me to the local hospital. The transfer of information was great. I got pumped into one of those little places with the curtains and so on. And then a woman came bustling in, and she had a lab coat on, looked very official and clearly healthcare related. She whipped up my sweater, and she started to put leads all over me, I guess to do an EKG or whatever. And so after a few moments, I said to her, excuse me, who are you? What are you doing to me? And I said, you know, I don't know whether you're a doctor, a nurse, or the janitor. She had not introduced herself, so she sort of was taken aback, and she did the introductions and so on. I was there, I went through all kinds of tests, MRIs and ultrasounds and whatnot, and after 8 hours, including the last 4 hours, just sitting in a room by myself, actually on a gurney hooked up to all kinds of stuff. Fortunately, I didn't have to go to the bathroom because there was no one to call, and I didn't want to bellow down the hall, and I was strapped up to everything. The doctor came in, stood at the door, and he said, "Okay, you have a gallstone, you need to talk to your family doctor, you can go now," and turned around and left. So that was that part of the experience. So then the next day I called my family physician. I said, you know, this is what happened. And she said, oh, yes, I saw that you had gone to the hospital, but I don't have any of the tests. And with this particular hospital, this was 2 years ago, I know that the tests, and they've told me it will take about 3 to 6 weeks to get the tests to me. So come in right away and we'll put you through all those same tests again. So yours truly has cost the system now twice for the same thing. Which didn't please me either as a taxpayer or as an individual who had to spend yet another afternoon going through all of these tests. Then she sent me to a specialist, which was fine. I sat down with a specialist and he said, well, you've got two choices. You can wait and see if it hits you again, or you can have your gallbladder out now. I recommend you wait. So I did. And you'll see here there's a dotted line, so I was happily waiting, and then 18 months later, I went through that same experience twice over in the span of about 6 weeks. And I'm holding my breath at the moment because this is not finished yet. I still have my gallbladder, and it still seems to be crummy. And I won't bore you with the rest of those, but just understand that the experience was a rinse-repeat type experience. So now I would like to share my observations about that experience. This isn't as fancy a diagram as the wonderful flowcharts that we saw that came together with the experience of Greg's journey, but there are elements to what I experienced that resonated with me when I heard about Greg's journey this morning. So for example, if you look at the piece that is the acute care system, that actually went pretty well for me, and it actually felt like I was in a system. The handoff between Telehealth Ontario and the EMS and the emergency department was seamless. I didn't have to lift a finger. I felt really reassured that everybody was passing information along, and when I hit the hospital, it seemed that they'd actually received the information. You'll notice I have only put 2 stars under the emergency department because I did have some issues with how I was treated there, but that's fine, and it's one institution, and those things can be rectified more readily in one institution. But once I got punted out of the hospital, I was then in the primary care system, and that's a much more confusing place to be as a patient, and certainly was for me. I went happily to my primary doctor, that was fine, and then I knew I had to go to a specialist, but the sensation I had is of being a football that was sort of lobbed over the fence to the specialist, who then more or less lobbed me back into I'm not sure where. Because there was no indication when I left his office over what I was supposed to do next, just sort of like wait. So that's kind of what I did. My primary physician is terrific. She's really been a great person. I can't complain about the treatment I get with her. But I feel that the handoffs between the acute care system and the primary system and then to the specialist, they really aren't there. And the place that I would like to see changes in the system are in those handoffs. So you'll see I have those little red question marks. Like, what the heck is happening? Who's calling whom? How do I know as a patient that the information has gone back and forth between the primary doc and the specialist? Very much the same issues that Greg Price had had. Who's in charge? Is the specialist supposed to be responsible for me now? Is it my primary doctor? I have no idea to this day. So I figure, well, I guess I'm in charge, but like, who am I? I don't know what's going on, other than if I'm in pain. So there are a lot of questions I have about that, and I certainly in no way felt like I was part of a care team once I was in the primary system. So that's my journey, and now I would like to switch gears and talk about how we can leverage experiences like mine and others in research, in measurement, and in research in general. You should know that I'm a member of the Research Management Committee as a citizen for the Tech Value Net, TVN, which looks into funding research for the health on the frail elderly. So I've been immersed in that for 2 years. So I've experienced, if you look at the partners section, I've experienced being a partner, and they have readily treated me as an equal partner when we sit down and discuss things from research strategy to setting priorities to evaluating the proposals that come before us. I feel like I've been really treated with respect, and I also feel like I've had an impact on the research agenda and the priorities. I have seen things shift because myself and my other colleague who's a citizen member have raised our voices and asked questions and opened the rest of the team up to the patient lens, and it's an important one. I've also very often, and I'm sure many of you in this room have been also, a guinea pig for research projects. I have been surveyed, I have been interviewed, I have partaken of focus groups. Mostly my experience with that is like, who dreamt up these questions? Why are they asking me this? What is the purpose of what they are doing? And I don't get a lot of feedback, and certainly I almost never have been given any of the follow-up or outcome of the things that I've engaged with. And so you sort of think, well, you know, I gave a half a day of my time or 20 minutes of my time, and I really want the system to be good, so I've really done the best I can to give the feedback, and then what, nothing? And that's been my experience, generally speaking. The other area where I'm now also getting some fledgling experience and hope to have more and hope to encourage more is as a collaborator on research projects where we help set, as a patient, we help set the question, the approach, not necessarily the methodology because we're hardly experts, but certainly the approach, the outcomes, helping to define the outcomes and so on, a real co-design approach. And we need more of that, particularly in taxpayer-funded research. This is our stuff on behalf of us, so we should have some say, and we should make sure that it's valid and so on. So I just wanted to mention that. So with regard to engaging patients or partnering, as we prefer to say, with patients at whatever level in research, I would like people to think that they shouldn't assume that we don't want to know why the research is valuable. We do. We're giving you the best of what we can, so we would like to know that there was an outcome to it one way or another. Don't assume that even though you're a human being and also a healthcare professional, and you may also have been a patient, that you necessarily know what we know as patients, because it's very hard, I think, as a healthcare professional, even if you are a patient, to lose the professional lens. It's always there as well. You've got bifocals. And those of us who are not healthcare professionals don't. We have a uni lens, and so monocles, if you will. We do want feedback. And the other point I wanted to make is that caregiver information is hugely important. My closest friend, her husband just had a brain aneurysm, and the doctors were asking him how it felt. And she said, "Excuse me, he hasn't a clue. I'm the one who was sitting beside him when it happened, and I can give you that information." So caregivers can give very valuable information. And finally, the point is that patients are not merely data points. I know we have lots of data, but we're not merely data points. We've got lots more to bring to the table, so please don't just treat us as data points. And finally, or very close to finally, our value. Our value is that as patients and caregivers, we are the only people who experience a system as a system. As you'll notice, both in Greg's story and in my story, we're the ones who go through, we touch every silo, we go in the in-between cracks, and so we have a lot to contribute for what we do there. So I just wanted to cover off some sort of points or perspective, if you will, on what patients want generally. And this is drawn not just from my own experience, but from a lot of the patients that I've talked to and interacted with, and from the tons of stories I've been through. So one thing we'd like is, please, healthcare system, join the 21st century. Let's get some of the practicals in place, access, time. People have talked about this a lot. I don't understand why my primary physician still will not email with me, but she's afraid of being sued for some reason, and she's afraid her time will be chewed up. So can we resolve that? Because really, I don't think those are serious issues. And when I went for a colonoscopy, they simply refused to email me the standard list of to-dos. They would rather fax it to me, and I told them it was over 15 years ago I got rid of my fax machine, so that wasn't on. So then they use snail mail. Okay, so we're dropping even further back. Other things that are really important to patients in their care, in a nutshell, patients at whatever level they're capable and interested in would like to partner with their care. And that may be for some patients that they want to defer primarily, and it may be for other patients is that they want to be sort of cheek by jowl with the healthcare professionals making every decision together. But in order to do that, and in order to be a true partner, we need understanding, and that means that we need full access to the same body of information. We need to feel comfortable about asking questions and not feel like we'll be talked down to, and not guarded away from certain types of truths, if you will. We want clear instructions and a validation that we actually really understood those instructions, support materials, and options to discuss further. I would prefer email, yoo-hoo, anyway. And we would like a team approach. I really felt uncomfortable being out there sort of having to kind of like knit my own team together sort of in my own way. It's really no can do for patients, although they do try. And our caregivers need to be part of that team. And I'd like to know who is indeed responsible for where I'm at now with my health challenges. Is it me? Is it my primary physician? Help. So, and then just to wrap this up, what's important to patients in their journey? We need to know who's in charge. We need to know what the care options are. We need support, and we need to be at the center of the system. With regard to measurement, I would really like to challenge us to figure out who measures the pieces between the crack, who measures the actual journey, because we can measure within those silos like crazy, but unless we actually measure that journey, we will not be measuring patient experience as it's experienced by patients. Thank you, and I'll turn it over to Jennifer.
All right. I'll pull it down first, Georgina. You and I might be the shortest ones on the panel. All right. As Gail said, I'm Jennifer Hartwick. I'm the Director of Business Process Development with Schlegel Villages. Just to tell you a few moments about who we are and what we do. We're a family-owned organization consisting of 13 villages, soon to be 14, that operate across southwestern Ontario. We operate in all areas of senior living, including long-term care, retirement assisted living, memory care, and independent living apartments. We have 2 villages currently under construction. Probably the most exciting one I like to talk about is our long-term care that's being developed on the campus of the University of Waterloo, where we will have our first dedicated long-term care learning, research, and innovation center being developed here in Ontario. So just a map to give you a sense of where I drive on any given day. We go as far north as Barrie, as far east as Whitby, and as far southwest as Windsor. So how do we decide what we do on any given day? We have 5 key success factors that we operate on. They are the apex of what we do on any given day, and it's how we hold ourselves accountable. What I wanted people to be aware is that customer experience is and has been one of those pillars for a great length of time. And over the last couple of years, we've been collecting a lot of data around our patient or our resident experience. But before that time, we were in the similar situation, as I'm sure many of you have been or are in the audience, in that we had a homegrown tool and we didn't really like the data that it gave us. So we spent a fair bit of time looking for another tool that was valid and reliable and would allow us to collect data that we could share and we could do comparisons with. So in spring of 2012, we gathered as an organization and we looked at how we could intersect our customer experience with our other quality indicators and our other success factors. As an organization, we had our leadership team, our frontline team members, family members, and some of our residents as part of that conversation. At the end of the day, we filled an entire wall full of sticky notes. On those sticky notes were what we felt brought the ideal customer experience together. And there was obviously a great diversity in that. We pulled those into themes, and what emerged out of that day were our 5 values. So to be present, to know me, to walk in my shoes, to follow through, and to earn trust. So after that year-long period of looking for a tool that was valid and reliable and would allow us to collect patient experience or resident information, we settled on an INTRI tool, the Self-Reporting Quality of Life Satisfaction Survey. It is a long-term care tool. It was designed specifically for those individuals, or at least those within formal care programs, and it allows us to collect their perceptions on a variety of quality life domains, so including relationships, environment, comfort, safety, food, participation, as well as meaningful activities. As I said, the tool is valid and reliable, so I know that it is measuring what it's supposed to measure, and it's reliable in that it consistently measures that kind of information. With using a valid and reliable tool, we can compare within our villages, we can compare across our villages, and our hope someday is that we'll be able to compare across the province or across the country, and in some situations, actually internationally. This slide is just to show you how some of the questions listed on the right, how they map very nicely into the actual 5 domains of our customer experience values. So if I need help right away, I can get it as an example of being present. Or I feel my possessions are safe, I feel safe when I'm alone, as an example of how you can earn trust. So it was a really nice realization when we came across this tool of how nicely it actually meshed with our customer experience values. So how does the INTRI tool work? Well, it measures quality of life through 31 different questions. Those questions actually map across these 10 different domains. The participants have the opportunity to rate the answer to the question based on a multi-level scale ranging from 0 to 4, so starting at never, ending at always. And because it's done in an interview format, the interviewer can actually code as them refusing it or not participating, are not actually being able to understand what was comprehended. The nice thing about this survey is that it can have an impact on the care transitions. And the reason being is that there's a differentiation between the questions. I can tell you at any given time, we never score 100%. There's no ceiling effect in the survey like you see with others. So based on that alone, we know that we can develop new programs and implement them to have an effect in the dimension that we see lower scores. So how do you get the opportunity to participate? Well, all residents in our long-term care homes have the option, if they're interested, if they have a CPS score or a cognitive performance score of 3 or lower. For those of you who don't work in the industry, our CPS scores are generated through the INTRI RIMDS assessments. All of our residents in our retirement living organizations have the opportunity to participate as long as they're not staying with us in our memory care neighborhoods. All participation is always voluntary, and it's anonymous. Verbal consent must first be given, and as I stated, all of our surveys are conducted by a personal interview by a team member who does not actually provide care for that resident. If you're a new resident moving in, you can participate twice within your first year, approximately 90 to 120 days after you move in, as well as annually around the anniversary date of your move-in time. In long-term care, I try and tie those surveys as close as possible to our RIMDS assessments so that I'm able to link those 2 data sets together. The nice thing about using an INTRI tool with another INTRI tool is that it's very simple to look at those 2 data sets together. So where do we stand today? Well, as an organization, looking at nearly 3 years of data, I can tell you that our 5 top scoring questions range in the 80-some% categories. I feel safe when I'm alone. I'm treated with dignity by the people involved in my care and support. I would recommend this site or organization to others. My privacy is respected when people care for me. And finally, my possessions are safe. But it wouldn't be fair just to tell you that. So where are we lacking? I participated in meaningful activities this week. Another resident here is my close friend. I have enjoyable things here to do on the weekends. Some of the staff here know the story of my life, and people ask for my help or advice. How many of you can imagine what your life would be like if nobody asked you for your help or advice today? Or what if they didn't ask you anything tomorrow, or for a week, or for a month? What value does that bring to your life? And this is what has really brought to our attention. How can we do that, and how can we implement that kind of change? This data became very powerful, in particular as it was coming from the voice of our residents. So what does it tell us? Well, we can sum it up as two very broad categories. We're doing a great job at meeting our contractual obligations, but perhaps we're falling short in the area of what some might consider adding meaning to one's life. The neat thing about this tool is because of its ability to differentiate between the questions, we've been able to use it as a program evaluation tool as well. I was able to link our data with another program called the Java Music Club. The Java Music Club is a mutual support group run by residents for residents. Its unique structure intervention helps participants reach out and support those that are lonely and isolated within their neighborhoods. We implemented this program in hopes of elevating that score of people asking for my help or advice. How perfect to do that if you could actually have peers helping peers and create that social environment. Sadly, I can show you the graphs. The question that we had hoped to increase on, we didn't. 24 of the 31 questions saw an increase in those post-analysis. However, the one question that wasn't improved on was actually people asking for my help or advice. The other thing we've been able to do is actually link our resident data with our team member data. So once a year, our team members, or our staff, have the opportunity to participate in an engagement survey. 48 questions, and with those questions, we've been able to link that data to our quality of life scores. One of those questions is, this place feels like home. We know just by increasing engagement alone within our villages that our residents tend to score more highly on this place feels like home. But what about people asking for my help or advice? If implementing the Java Music Club program wasn't going to do it, how else are we going to increase that? It turns out just by having a more engaged workforce, we are actually increasing the value or increasing that positivity around the response from our residents to that question alone. So where do we go from here? Well, I can tell you that doing this on a paper form, although it's doable, it's not the easiest and the most cost-efficient way to do it. So we're working on an online platform that will allow us to have access to that data at a touch point. So when a survey goes in, we'll be able to generate a new report that shows what the new scores would be coming out of that. And then, secondly, from there, looking at proxy information. So if we can't gauge satisfaction from our residents alone, can we get it from somewhere else? Because some of our residents don't have that ability to vocalize or verbalize that information anymore. So looking at families and looking at quality of life satisfaction scores as rated by our staff as well. So I guess the take-home message here is, as important as the data is, it's not about the data, it's actually about the dialogue. It's the communication that happens once we have that information that's really allowing us to make that change and to make business decisions based on, what it is we are providing and what it is our residents are telling us. And that's everything. Thank you. At this time, I'm going to turn it over to Georgina Velthurst.
Thank you for the opportunity to share the work of the LINS on the measuring patient experience. So the patient experience measurement work is part of a larger body of work in which we started with a framework, which is what you see here. Then we moved to developing a patient experience measurement survey, which we're in the process of doing now, and that work is very much still in progress. And we've also started to do some work simultaneously at developing a patient engagement framework and toolkit. So the idea is that we'll use these three things simultaneously. In the time that I have today, I'm just going to be talking about the measurement piece, the survey. So in developing the survey, we started with looking at patient experience surveys that already exist. We were looking at a survey that would look at patient experience on a systems level or a regional level. So some of the surveys that we looked at included the NRC Picker, the U.S. Agency for Health Research and Quality's tool called the Consumer Assessment of Healthcare Providers and Systems Measurement, as well as the Patient Assessment of Chronic Illness Care survey. The questions that were relevant to the circumstances of many patients or many patient groups were identified in that review process. We also, throughout the development of the tool, had advice and guidance from experts in health evaluation. So some of the folks that we engaged included the Institute of Clinical Evaluative Studies, the Canadian Institute for Health Information, and St. Mike's Lee Cushing Knowledge Institute. Through this process, 36 experience questions were identified that were included in the pilot survey. To test the pilot survey, then we used a standing panel of volunteers from VoxPop Labs Insight Panel. VoxPop had a pool of 65,000 Ontarians at the time that we did this pilot survey in the summer, and that number is continuing to grow. The sample size that we used the Central LHIN as the beginning sample, and we used 500 residents who had received care in the Central LHIN, 250 from the Toronto Central LHIN, and an additional 250 from other regions and other LHINs in the province. The benefit of using the VoxPop Labs was that they had an ability to support large N studies. And they also had an ability to target diverse respondents. In their standing panel, they had profiles on over a dozen demographic and attitudinal variables that we could leverage. So for our pilot, these variables were weighted to ensure validity as well as the ability for robust comparability of subpopulations. In the test survey, we were looking for feedback from those that we engaged in terms of what questions did people struggle with and which ones were easy, as well as which questions did people feel were most important and least important to the quality of their health care. We also wanted to collect very preliminary information about patients' experience so that we could get a sense of where the most useful findings lie. The third stage was to use a residence review panel. So of the 1,000 participants that we used, included in the pilot survey, we looked at those 500 from the Central LHIN. And in this survey, people had been asked whether they would be willing to participate in a day-long review panel process. We had 102 people that volunteered their time on a Saturday. Those 102 people were interviewed, and 24 of them were selected based on age, gender, geographic distribution, as well as making sure that we had a range of people with a range of experiences in using the healthcare system. This group met for a full day in August of this past year to learn about the healthcare system, to consider the needs of all residents within the geography, and to offer guidance on how to measure and improve the experience of patients and caregivers. The panel was provided with an opportunity to do a deep dive on two questions: what's most important and what was missing in terms of the survey. From this input, the survey was finalized. This slide shows what emerged as what was considered most important. The top four: ease of access to care, respect and shared decision-making, information, communication, and education, coordination, and integration were important to all subgroups that were surveyed. The bottom four, the level of importance ranged depending on the subgroup. So top 4, important across all groups. Bottom 4, depended, the level of importance depended on the subgroup. Let me share some insights from the analysis of the pilot that were applicable to the survey design. First of all, women and men reported similar experiences concerning respect, access to care, privacy, and pain management. But women reported receiving less information, less organized care, and less support when returning home. Immigrants felt more respected and more included in decision-making than those who were born in Canada, but were less likely to know what to do if they needed to come back or needed further information and who to contact for that information. People with lower family incomes were less likely, people with lower family incomes were less likely to feel that information from providers was easy to understand, that the provider spent enough time with them, and that they knew who to contact if they needed further assistance after their engagement with the healthcare system. Young and old reported similar experiences concerning communication, respect, and emotional support, but young people were more likely to have difficulty accessing care after they left, particularly on evenings and weekends. They also experienced care to be less organized. For those with poorer health, those folks reported worse experience in many areas of care, but especially with access to care and help at home. Oh, I hit the wrong thing. There we go. The final survey questions have been broadly distributed across the 8 dimensions that I presented earlier and based on level of importance. In determining which questions to include in the final survey, questions that captured discrepancy in care were given a higher level of priority for inclusion. Additional questions were added based on the review panel feedback, as well as questions that were more relevant to subgroups. Although there are many strengths to the survey design and the administration process, we have identified at this point a number of challenges. The survey is administered online, and we don't have an equitable online presence across the province. So some of the LHINs that have lower online presence are currently in the process of looking at how do they augment and how do they want to augment so that they get better coverage in their LHIN and more representative coverage. Secondly, the online approach doesn't work for all marginalized populations. And some of the ones that we've already identified is individuals who are in long-term care facilities. They're probably more likely to be able to respond to a survey when it's in this kind of process. Finally, surveys that are available in English, they will be available in both English and French, and so if that isn't an individual's primary language, they may also have some difficulty participating. We are now at the process, or at the point that we're ready to launch. The plan is to conduct the survey on 6,000 residents across the province every 6 months. And we're currently looking and working with all of the LHINs in terms of looking at what the specific analysis needs are and what can be most useful in terms of the planning work of the LHINs. The idea is that LHINs will use this information in their health services plans, in their project planning, their initiatives, as well as having this information available for health service providers. So I'm one of quite a team of people that's working on this project, and as I mentioned, we are still we have not yet launched this. We're hoping to launch in the near future, but my contact information is here, and should you desire further information, either I'll engage with you or others on the team that have been involved with me. Thank you. I'm going to hand it over to Kira, who's going to talk about the national perspective.
So as you've heard, we're going up and up a level. We started at the patient, and we're going to end at sort of national and international to some degree. So I'm just going to take you a little bit on where CIHI is at in terms of its process and developing a patient experience survey, and talk a little bit about where we are in that process, but also what's available from the national and international comparison perspective. So really, I just wanted to, I mean, this is preaching to the converted here. I'm not going to go over any of these points. We all know through this presentation and others why patient experience matters. One of the things that you may not know, though, is that recently CIHI did a indicator consensus conference, October 15th and 16th. I was actually scanning the audience to see if anybody had been there, but I couldn't see anybody. But one of the things that was loud and clear in that conference was PREMS, patient experience measures, as well as PROMs, patient-reported outcomes, is high on the radar of at least 65 leaders, policymakers, decision makers, researchers, and clinicians across the country that we spoke with at this conference. So there is a loud and growing louder voice for measuring patient experience across the country, which is, I'm sure, music to your ears and was certainly music to ours. We started really this journey quite a long time ago. This framework was actually born in 2012, but we started our journey at CIHI really in sort of 2010 and even before that, valuing the importance of the patient experience for at least a dimension of understanding health system performance, which is really what we're interested in. You can see there in sort of the orange box, well, they look pumpkin on your screen. They look orange on mine. Right in the middle of all of the patient outcomes is really or the patient outputs is really related to patient-centeredness, appropriate, effective care, and how are we going to know from the patient perspective if all of those things are achieved if we don't ask them. So really, we started in 2010 sitting at an international jurisdictional committee, asking them to help us develop some measures that we could add to our thoughts around balanced scorecard measurement of patient experience. In 2011, after sitting at that table for quite a period of time, several of those jurisdictional members approached CIHI and asked us to accelerate the work. They asked us specifically to take a leadership role in developing a pan-Canadian standard survey that could develop standardized comparable measures for patient experience in the acute care setting. So that's what we did. You heard Georgina talk about the HCAHPS tool. It was embedded in this survey, and we added 23 Canadian questions to it. We worked very specifically with jurisdictions. We did some cognitive testing and pilot testing, developed a minimum data set for collection, and are now working really where we are is with our early adopter jurisdictions, and I'll tell you about that in a minute. And the survey itself is endorsed by Accreditation Canada for their processes for accrediting hospitals in Canada. So here's really where we are. We have a standardized tool that is available on our website for free, non-proprietary, in English and in French, that can be adopted and used today. We have a patient experience procedural manual so that it can be applied in a standardized way, and we have a minimum data set. We also have vendor specs, as you see in the question mark at the top there. We do have vendor specs available as of the end of October, because we are now in sort of what we're calling phase 2 of the development. Phase 2 of the development is developing a patient, sort of a data collection and reporting system associated with this survey. We started the development in spring 2014, and this is really our first attempt at developing a database collection and reporting system with shared funding from jurisdictions, and that's where our early adopter jurisdictions come in. So we have 5 jurisdictions: British Columbia, Manitoba, New Brunswick, Ontario, and New Brunswick, Ontario, I'm missing one, Manitoba, Alberta, thank you, whoever yelled that out. Darn. And those are our early adopters who have contributed funds to developing the reporting system. And we actually have two jurisdictions, two regional health authorities in Manitoba, as well as Alberta itself, who has implemented the survey and are ahead of us in collecting data before we have the data collection and the reporting system developed. We know what we're hoping to accomplish, and we know in some ways what you're hoping to accomplish with comparable data being available, certainly for improvement, for comparisons, and for benchmarking. We also wanted to make you aware of some of the work we're doing in terms of developing some of the measures. We're working with a technical working group to create some of the pan-comparable measures from the survey. We've had our very first sort of kickoff meeting with our expert advisory group. Again, I think Elise and others will be happy to hear there's a patient voice on that working group so that we do capture what is important to patients. But we are sort of moving in that direction of developing those measures. Early stages. I also wanted to just briefly talk to you a little bit about the international comparison part. So there's two components here that I wanted to make you aware of. The Canadian Community Health Survey was redeveloped with Statistics Canada for new survey. New parts of it are going to be implemented in 2015. CIHI actually worked quite closely with them to redevelop the survey and embedded some patient experience questions in the survey that are part of the OECD questions. So on a go-forward basis, researchers will be able to get access to patient experience measures that are comparable with OECD measures starting in 2015, at the end of 2015. You heard that our survey itself, that's the Canadian Patient Experience Survey, inpatient care, is you can do international comparisons with that with the HCAHPS tool that is primarily used in the US. So here's our priorities. We're working with technical groups. We are developing and finalizing the measures for the indicators. We're designing reports that will make sense back to providers of the data. And we're exploring opportunities to linking the patient experience data with our other administrative data to make it more robust in reporting. I can talk to you offline a little bit about the questions around a mode study. It's probably a little bit longer of a conversation than the 3 or 2 minutes that I have left. But we are sort of undertaking the concept of a mode study. And really that's just looking at sort of the difference in responding between online surveys, telephone surveys, and paper-based surveys. Our future directions, we are looking at incorporating and developing benchmarking, and we are also looking at other sectors to expand into. We've actually been part of conversations with this same interjurisdictional committee about trying to determine whether there is a logical one tool that can be used in the long-term care environment that we could start potentially supporting and moving in the direction of collecting data at a national level and reporting on that. And we are also looking at the opportunities to start collecting emergency department data at a national level and developing pan-Canadian comparable data for that. So that's really where we are, and I am now going to turn it back to Gail.
Tall again. So thank you, Kira. Thank you, Georgina, Jennifer, and Elise. This has been tremendous, certainly for me, and hopefully for everybody in the audience to hear these different perspectives as we sort of graduated up from that very patient level to the provider, long-term care home level, to the LHIN level, and then the Canadian, and then the international piece. And I think what it did was tied together the opportunities that patient experience measurement presents. This next slide that I wanted to just talk briefly about speaks to the art and science of patient experience measurement, and I think draws the themes through the various presentations that we heard just now. And so this is just a bit of a collection of some of these summary statements. Those being, first and foremost, that patient involvement in the process of patient experience measurement is critical from the beginning to the end, and I've added back again. I think we heard from Elise that after you've collected the information from me, tell me what you did with it. Tell me how it's informing change within the organization. We also heard the importance of multiple perspectives. So today we focused on patient experience, but also throughout the conversation we heard how important it is to make sure that the caregiver is a part of this as well. And I've added to this that staff experience is also critical to give us a comprehensive view of what's going on. The importance of collecting the right dimensions or information related to the right dimensions. What are the right dimensions is something that is debated in the literature, and you can draw from the internet a zillion articles out there on patient experience measurement, which is the good news. The bad news is which do you take? Which dimensions are right for my purpose? So a lot of critical thinking needs to go into an organization's decision about which questions for which purpose are there. Kira spoke about the importance of PREMs and PROMs, and again, for comprehensive measurement, it's hugely important that we're thinking both about the experience measures, but as well about the outcome measures from the patient perspective, understanding the difference between those and weaving those in together to get that comprehensive picture is important. One of the other pieces, and certainly through the literature this is something that emerges as well, is that Ontario lacks a set of standards around patient experience. And there's some marvelous examples starting to emerge in Ontario actually now, as well as internationally. The National Health Service is one of the ones that I always draw on, the NICE patient experience standards. And they've got a very nice, clear list of what we should be delivering to our patients and what we should be measuring ourselves against. The next one is around the continuum of care, and we know that there are a number of instruments that exist, different measurement approaches within each of the sectors of care, whether again it's for quality improvement or right up to something that's going to be publicly reported, but we also have to start to get at that piece that Elise talked about, which is what's happening in between these silos, those handoffs in care. And it's so exciting to hear the work that's happening at the LIN level to begin to understand the continuum patient experience story to make sure we're capturing that. As we look at projects like Health Links and other integrated quality improvement efforts, how are we capturing that information? One of the other things I've put up here, and it didn't come up too much in our conversation today, but the importance of timely data. And when I refer to timely data, I'm thinking actually in two ways. Timely data is important, that we're capturing the experience information very soon after the patient or the resident has had the care experience. In the resident case, it's ongoing. But the other piece of information is making sure that we're giving that data back to providers, or that the providers have access to that data very quickly so it can inform the quality improvement quickly and ongoing. Next one on the list is increasing use of new technologies. So as we have changed and evolved, or as that evolution of the art and science of patient experience measurement has taken place over the decades, we've gone from sort of clunky surveys to more sophisticated surveys, and now the technologies to capture the information are improving as well. We've been watching and tracking some very interesting technologies that send just a couple of questions immediately after to a mobile device after someone's had an appointment, or other ways in which we can engage those with less cognitive function to be able to provide information back on their experience in long-term care homes. So these new technologies, these new approaches are developing, and we need to keep pushing that envelope forward, testing them, figuring out what's working, what's not. The last is learning to using the successes of others and learning from those and creating conversations around that. And that can be at the individual provider level or the organizational level to drive quality improvement. As Kira talked about, the opportunity for comparisons across organizations to benchmark and to hold ourselves to higher standards. And then obviously the role that public reporting can play in that as well. So those were just some of the themes that we heard from our presentations today. But where does all this lead us? And this next slide just starts to address what some of those next steps are. And if I had to sum it up in just a couple of bullets from a time perspective, there is a need, I think, for an Ontario-driven, evidence-based body of literature to continue to make sure that we understand the impact and maximize the impact that engaging patients in the process of care and measuring their experience as they go through it continues, and that we're continuing to advance that science. It's hugely important from the perspective of making sure we're filling gaps, and there are gaps out there. Well, we've heard a huge amount of activity, both from each of our presenters as well as from what the literature is telling us. We know that there is a risk of lack of alignment or overlap, but at the same time, we also need to be able to identify where there's actually no activity taking place and make sure we're addressing that, and also to maximize that learning and leverage the opportunities for reporting the information, comparing ourselves to one another, and then benchmarking what really good patient experience should be at and strive towards that. My last bullet point that was on my original slide about today's objectives was to talk a little bit about the role of HQO. Whenever I talk about what it is that HQO does, I say report and support simultaneously. So there's a lot of activities that are happening in the experience measurement around things like the quality improvement plans, where there's patient experience questions on all of those, where we've got the primary care patient experience survey work that is in pilot right now, that we're looking at supporting organizations through things like the practice reports and a number of other mechanisms and levers. But we're also tremendously committed to making sure that we're reporting on patient experience measurement. We heard it this morning from Joshua, and we heard it this morning from Irfan. We just heard it from the minister, and we've heard it from others in other presentations in this conference, that reporting on patient experience will continue to help us with that evolution that is taking place, that everybody in this room believes in, but we just need to keep driving forward. One of the commitments that is a part of that HQO is making is to have a provincial performance patient experience measurement table. And this is something brand new that HQO is bringing together in partnership with the LIN, with Central LIN, who will co-chair this with us. And the opportunity of this group is to come up with a framework for patient experience measurement for the province of Ontario that starts to track and map all the activities that are going on and what the purpose behind those are, where those gaps are, where the opportunities to leverage the data that we are getting are, and to continue to push that forward. So these are just some of the commitments that HQO is making to being a part of this with our health system partners, many of which are in the room. So that finishes the sort of the formal part of the conversation. I mentioned that there is a clicker that was handed out to everybody at the beginning. And we wanted to just do a little experiment with everybody on this one. We've got 3 sort of scripted questions. And what we are going to do is practice looking at or using the scripted questions to feedback information. And the reason why we wanted to do this was to partly get a little bit of audience participation, but partially to get some information from this converted group that's here today. So what I'm going to do is just this first warm-up question, I'm going to read it out loud and the response options, and then when I say go, we're all going to enter in what our response is, and then we're going to have it appear up on the screen. And then I'm going to do this 2 more times with questions that were actually done with healthcare leaders in the United States. And I want to see how our responses might compare to the responses there around patient experience. So first of all, the warm-up question. I'm attending Health Quality in Ontario's HQT in my capacity as 1, patient caregiver, 2, member of the public, nurse, nurse practitioner, PSW, allied health professional, pharmacist, physician, researcher, scientist, statistician, or epidemiologist, student, or 9, senior executive management or administrator. So if everybody can enter in your number, that would be a great start. The countdown is just giving everybody 10 seconds to enter in your data. And our responses are A lot of senior executives in the room today, management and administration. So it tells us a lot, which is actually really great. I'm excited to see that as the result. So let's move on to the next question. This next question is, what is the top factor that would enhance the success in your organization's patient experience measurement efforts? There are not 9 response options, only 6. And some of these may seem like they're overlapping a little bit, but I wanted to make sure that we lined the questions up that were asked in the US exactly with the ones that were asked here. And as we respond to this, we will then also see what the comparison is simultaneously. So choose your response options from strong, visible support from the top, clinical managers who support patient experience, formalized process review and improvement focused on patient experience information, formal patient experience structure or role, ongoing internal communications path, and others. So top factors that would enhance the success in your organization's patient experience measurement efforts. So let's go and enter in our responses now. And let's see what we come up with. There we go. Strong, visible support from the top is quite the clear leader in this particular one. So great response. No, that was the US one. So there we go. Some interesting learning there. All right, and the final question. What's the biggest roadblock facing your organization's patient experience efforts? Patient experience efforts pulled in too many directions, other organizations' priorities leading to reduced emphasis on patient experience, cultural resistance, lack of support from physicians. Again, I didn't come up with these response options. Budget constraints, or other. So again, 10 seconds on the clock to enter in. And this time we'll see if I can get the comparison from US to this group's responses correct. So again, very clear, this group, number 2, the organizational priorities leading to reduced emphasis on patient experience. Right. So those were the formal questions, and now what we would like to do is open it up to the folks in the room to ask questions that you have. There's a couple of microphones around the room, and the panel is ready to respond to questions. If there are any questions. Yep, Kirk? Yep, so I think there's actually a number of activities that are happening both in the reporting as well as the supporting side of primary care. So some of you may be familiar with the project that is in process now or in pilot testing now called the Primary Care Patient Experience Survey Tool. And that's a project that has been developed in association with all the primary care associations. It was started about a year ago, and as I said, it's in pilot testing now. And this is an instrument that is being standardized to every extent possible across all the different models of primary care in the province of Ontario. It's intended as a patient experience tool that is to drive quality improvement, and it's not specifically to public reporting. But as we move forward, increasingly, I think there's an opportunity for, if there is standardized data collection protocols, to be able to capture that. So that's at the QI level. At the other levels, at the public reporting level, there's a number of surveys that are actually capturing a little bit around the primary care patient experience. And those include the Ministry-Driven Healthcare Experience Survey, which is a population-based survey, as well as the Commonwealth Fund has a survey that is run. It's actually 3 different surveys. There's a survey focused on provider experience, one on the general population, and one on older adults, 55 years in age and older. The Commonwealth survey is actually, you'll see some of the results in the Measuring Up report, which was handed out today, launched today for the 214 version of that. And in that, you will see some comparisons of Canada, Ontario, in that report that gives us a glimpse of what's happening in primary care. So there's actually a fair amount of activity that's going on there.
Gail, if I could just add there, the CCHS survey data that I talked about, that was the advantage questions on patient experience, that's completely related to primary care.
Yes.
Those questions in particular, the OECD questions. So you will see that at a national level. The questions are, along the lines of, given your most recent experience with your doctor, did you do this? Did you do that? Did you feel this way? Did you feel that way? So it'll be a subsample of the CCHS population, but it will be at a population level in primary care.
Great. There's another question?
Yeah, sort of distracted by a gentleman who lost his scarf, so don't go home without it. Glad to be of service. You hear a lot of general remarks about the objective of healthcare these days is really to provide value. And value is, I think, is what is it? Everybody tell me. I think it's outcome over dollar, something to that effect. So I'm wondering if you have examples in which the PROMs, so patient-reported outcomes, if we're going to be patient-centered, and really focus on customer value, if you will, the extent to which the PROMs are being used as the foundation to assess the value of the service.
Kira, do you want to start with that one?
I think in Canada and in Ontario, we're at the very early stages of developing initiatives around PROMs. So there are some pockets of work that are related to evaluating the successfulness of an intervention. But I don't know, at this point, there is no, as far as I know, there's no systematic initiatives, either in Ontario or Canada as a whole. Again, there are pockets, but not systematic.
Part of the question, if I may, part of the question comes from some of the work I've seen where there's a question about, okay, patient-centeredness, yeah, we all know about patient-centeredness, but really does it improve outcomes of service?
Right.
And yet it's a bit circular because, or maybe it's because if the outcome of the service really should be defined by the patient.
So CAIA is actually hosting a forum, it's an invited forum in February of next year, solely around the whole topic of PROMs. And we're bringing in international and national speakers to talk about what it would take to instill in Canada a collection methodology around PROMs. So that's the best that I've got.
That's pretty good. Yeah. Terrific. I think actually we are probably supposed to be wrapping up about now and heading out to hear Bob Bell's presentation. I think that's taking place at 3:15, so you've got time for a quick break, stretch your legs, and head into the next. Thank you very much for joining us.